And good afternoon. It's 12:09 in Florida here at the Duke Spine Institute, and we're streaming live spine surgery. Our patient is somebody from North Florida. She's here because she's been in pain for years. And folks, her story literally breaks my heart. She's a really nice lady, her and her husband. They heard about our center. They came down here. And just take a look at her x-ray, okay? This tells everything right here. Can you see this x-ray, Henry?
Yes, we can.
So I've been telling you all for years, avoid open spine surgery, invasive spine surgery. Here's why. Look at what they've done to this woman. All for profit. Really, that's it. Just to profit off her back. And these doctors will do this to you anywhere in the world. Be cognizant, be wary, be alert, avoid it. So first of all, we've got fusion from L4, L5, S1, okay? We got big screws, and I'm impressed with the screws because they did a good job putting them in. They're nice big screws with big treads, well positioned. Look at the cages. You can see the triangular shape of the cages. Those are called tantalum markers. They're little metal, kind of like beads in the cage, show you where the cage is to show you if it's moving out of position. So she's got cages, basically disc replacements. She's got big screws, and she's got what's called the peak rod. The peak rod is the biggest joke in the industry, besides robotic surgery and spinal cord stimulators and ultrasonic surgery. Show us the peak rod, Jordan. The rod. Go back to the rod. There it is. Look, you can see the cap. Look at the cap of the rod. There it is, like a little helmet. Now the rest of the rod is invisible, right? Normally we see a metal rod, but it's invisible. Why is it invisible? Because it's made out of PEEK, polyether ether ketone, which is basically a hard plastic. So they call this shit a flexible fusion, right? A flexible fusion. All right. That's like jumbo shrimp, right? There's no such freaking thing. The point is, fusion means the bones are solidly fused together. They don't move at all. That's what fusion means. So they sell this surgery as a motion-preserving fusion, which is complete bullshit. There's no such thing. But they use these PEEK rods, and they sell it hard with these rods that are flexible. But you're still fusing the spine. Now, on top of that, as if that fusion wasn't bad enough, she fell for another surgery. Can you see it? See the giant, the giant triangles down in her sacroiliac joint. Okay, she had a sacroiliac joint fusion. Cha-ching, cha-ching, the surgeon, the hospital, they're making gazillions of dollars. The medical device company, gazillions of dollars. So let's look at the price of this. The screws are about $1,000 a piece. So that's 6 screws, $6,000 profit. Then you got those 2 rods at about $2,500 a piece. That's another $5,000. You got the cages at about $4,000 each, $4 to $5,000. That's $10,000 there. You got those metal triangles that are hammered and pounded through the SI joint. And by the way, they don't work. They're supposed to fuse the joint. They don't work. The joint is still hurting her. We're going to have to fix it today. She still has SI joint pain. And on top of all this, as if she wasn't a recipient of enough metal and hardware and enough profiteering from the implant companies, they had to go one step further and sell her on the old spinal cord stimulator. Oh, it's the best treatment for back pain. Nonsense. It's not. It's just another thing they put in and make $60,000 from the insurance company putting it in. So this woman's gotten the triple whammy. She got the fusion with laminectomy, she got the SI joint fusion, and she got the spinal cord stimulator. And I feel horrible for her because she's trusted her doctors to do what's right for her, and they put all this stuff in her, and here she is paying out of pocket to have back surgery done properly. We're going to fix the L3-4 on both sides because she has pain up here. We're going to fix her SI joint. We're going to fix her piriformis muscle. She has all of those, and none of them were addressed by the other doctors. So let's get started, Henry. Let's talk, since we're talking about the sources of back pain, let's show the audience the 30 different causes of back pain while I get started. I'm Dr. R. Duke Machen with the Duke Spine Institute, and we're going to discuss 30 causes of chronic back pain. Chronic back pain is back pain that lasts longer than 6 weeks, and there are 30 causes of chronic back pain. The most common cause is going to be a disc injury. Disc injuries such as disc herniations, disc bulges, disc ruptures, degenerative disc disease account for 86% of chronic debilitating back pain, and they are totally fixable with the proper treatment. The best treatment for disc injuries is Duke laser disc repair. Let's take a look at the 5 lumbar discs that can be injured. The most common disc to be injured is L4-5, followed by L5-S1, then L3-4. The L1-2 and L2-3 discs are far less commonly affected. Next, we have facet joints. Facet joints are small joints located behind the discs in the back of the spine. There are 10 facet joints, each paired left and right, L1-2, L2-3, L3-4, L4-5, and L5-S1. The most common facet joints to cause chronic back pain are L4-5, followed by L5-S1, followed by L3-4, in that order. After the facet joints, which account for approximately 10% of chronic back pain, we move on to the sacroiliac joint. The sacroiliac joint accounts with the piriformis muscle for approximately 4% of chronic back pain. The sacroiliac joint is a joint located between the tailbone or sacrum and the iliac bone. There is a left and right sacroiliac joint. In this diagram, you can see the joints turning red, indicating inflammation and pain either in the left or right sacroiliac joint. These sacroiliac joint injuries and pain can be treated most effectively with the Duke plasma rhizotomy of the SI joints offered at Duke Spine or Duke Joint Institute. The fourth most common cause of chronic back pain is a piriformis muscle injury. The piriformis muscle is located in the buttock, and there is a left and a right piriformis muscle. The muscle gets torn, unfortunately, when people bend the wrong way. This usually occurs in patients with orthopedic problems such as hip pain, knee pain, or back pain. By bending improperly, they put the muscle under too much stress and they tear the muscle. The torn piriformis muscle causes severe debilitating pain in the top of the buttock. There is a left and a right piriformis muscle, and this can be treated most effectively with the Duke piriformis muscle release. This is performed percutaneously with a 4mm incision. The sciatic nerve does run through the piriformis muscle, and many patients with piriformis muscle syndrome also have sciatic pain down their legs, with pain, numbness, tingling, and weakness in the leg that's affected on the side of the piriformis muscle. Piriformis muscle can be treated with injections such as steroids, Botox, PRP, or stem cells. However, those injections always wear off and the patients end up coming back with the piriformis muscle pain that reoccurs. The most definitive treatment for permanent relief of piriformis syndrome is a piriformis muscle release. Next, injuries to the bones of the spine, such as the vertebral bodies, with trauma can cause fractures of the vertebral body. Vertebral body fracture is diagnosed with X-rays or CAT scan or MRI, and they're treated with injection of cement into the vertebral body. Looking at the vertebral bodies, the most common to be affected is L1, followed by L2, then L3, L4, and L5. The sacrum can also be fractured. Finally, the coccyx is the last cause of chronic back pain. You can see in the diagram the red coccyx at the bottom. This comes usually from an injury where the patient falls on their bottom, sustains pain at the tailbone, and this can be treated with injections of the coccyx ligament. These are the 30 most common causes of chronic debilitating back pain, the most common being the disc, causing 85% of chronic back pain, followed by the facet joint, causing 10% of the chronic back pain, followed by the piriformis muscle and sacroiliac joint, which cause 4% of chronic back pain, totaling 99% of chronic back pain, which is totally fixable and curable with the right treatment. Thank you. I'm Dr. Duke Machen. Thanks for joining us. And welcome back. You can see from our video that there are 30 different causes of back pain. Now, Jordan, stay there on the AP view, folks. Right now, we are in the first phase of the Duke laser disc repair. Our patient is laying on her belly, and I want to give me another AP. You can see we're placing 2 needles. No, Jordan, I want you to give me an AP shot. once I get these needles in the right spot, then we're going to do the Duke laser disc repair. And take a look at her AP view. This is really sad. I feel horrible for this woman. No, I want to see the SI joint. You guys see the screws and rods and cages in the spine, but I'm also going to show you what they did to her SI joint. All right, she's got basically a bladder stimulator too, I think. Yep, on top of everything else she has. That's amazing. Well, if anybody watched the $6 Million Man when we were kids? Huh? Byrne does? Lee Major?
With Mel Brooks?
No, Lee Major. $6 Million Man, was that what it was? Or was he the $6.5 million? $6 million. All right, so there was a show we grew up as kids in the 80s kids. It's called The $6 Million Man. He had all this technology implanted into him, so he became superhuman. Well, this is what technology looks like in 2025. This is, 40 years later? But it doesn't make you better. That's the problem. The $6 million man got $6 million worth of technology. They gave him bionic strength, super speed, and he can go get the bad guys and take them down. But look at this. This is the $6 million woman of today. And she's got, show us the screws, the bolts going across her SI joint. Look at that SI joint that's fused, right? And she still has pain. We're going to be treating her SI joint today because the pain is still there. A study just came out just 6 months ago showing that patients that got SI joint fusions still had pain in their SI joint, and the fusion never helped. So it doesn't help the patient. It helps the hospital make money. It helps the surgeon make money, and it helps the company that manufactures those metal implants make money. Let's go back to a lateral view. Any questions from our audience?
At this moment, no current questions.
So if you couldn't tell, folks, watching Duke Spine Institute Live Spine Surgery, I'm Dr. Duke Majan, CEO and founder. My mission is to educate the public about the problems we're seeing today in the spine surgery world or spine care world, and try to avoid it for yourself, not to get caught up in these issues. All right, here we go. We are in the disc at L3-4. Now, this patient has what's called adjacent segment disease. So she had a fusion, and honestly, the fusion to me looks pretty good. The surgeon did a good job technically. The screws are in the right place, they're the right length, they're the right caliber. There's a curvature to the spine. I don't like the rod being what it is because I think that's a fake rod. The cages are well positioned, the height in the disc is well preserved. As fusion occurred in the interbody space and posteriorly, they did a posterolateral combined fusion. The bad thing about this is that it wore down the disc and facet above, and that's what fusions do. All right, she's got the two discs that are fused, and now above it she's got arthritis at L3-4. Her facets are full of arthritis too. So we're going to inject a little dye. She's asleep. This is not to test what this disc is painful. I already know it is. But this is so that we can stain the tear and the herniation so we can visualize it with our endoscope, which you're about to see. Any questions?
At this moment, no current questions.
Let's show the audience how we do endoscopic spine surgery to cure people's back pain.
Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain. A 1/4-inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK L349 6922.
So, coming back to the Duke laser disc repair, that's the procedure you just watched on the video. The Duke laser disc repair is a surgery done with a 7mm incision, tiny incision. It's done minimally invasive. As a matter of fact, the most minimally invasive surgery in the world for actually fixing back pain. And our procedure is supposed to be done instead of all this other stuff that she had done. Our treatments don't involve putting any metal in your body. There's no hospitalization. There's no downtime. There's no pain meds. Our patients do not take narcotics. No. Let me see. Our patients do not take narcotic painkillers after surgery. They take Tylenol at most, or a muscle relaxer. That's it. So we don't prescribe these patients narcotics. They don't need narcotics or opioids, which are dangerous and addictive. Now, if she had, when she had her fusion done, she needed narcotics. When she had her SI fusion done, she needed narcotics. When she had her stimulator put in, she needed narcotics. But she does not need post-operative, after surgery painkillers for this surgery, because this is such a mild surgery and it does not cause any significant internal trauma. We've never had a case where we've had a complication. There's virtually no bleeding. You can see how much blood we've lost for the whole surgery. That's it. That's like virtually nothing. Okay, so no bleeding, no hospitalization, no metal, no fusion, no loss of movement. It's all natural. We're just helping her body heal a damaged disc. And that's what should have been done on her first two discs. If she had that done, she wouldn't have needed this surgery. She should not have had the SI fusion either. I'll tell you right now, folks, it's the year 2025. By 2030, SI fusions probably won't be covered by insurance anymore, because frankly, they just don't work. They're dangerous and they're expensive. And they don't work and they're unnecessary. There's a much better treatment called Duke plasma rhizotomy. All right, we are inside the L34 disc. We've gone through the herniation, pushing the herniation back in to the tear, where I'm going to remove it using a laser and some surgical instruments. Any questions, Henry?
At this moment, no current questions.
Oh, do we have any viewers?
Yes, we do. We have many viewers across all of our social media platforms, so we're good there.
Great.
So in the meantime, we did mention the Duke plasma rhizotomy. Why don't we show the audience of how it is that how it is a facet causes lower back pain, and how it is that we cure it with the Duke plasma rhizotomy.
Yeah, so Henry is going to introduce you all to a different cause of back pain than what we're treating today. We're not treating facet pain, but some patients get facet pain in addition to their disc pain. We're fixing disc pain. This is called discogenic back pain. Discogenic back pain is back pain that comes from a disc injury like this one. Facetogenic back pain is back pain that comes from an injured facet joint. And sacroiliacogenic back pain is back pain coming from a sacroiliac joint. And piriformisogenic back pain is back pain coming from a torn piriformis muscle that's inflamed. So we have very different causes of back pain. Each one has their own treatment that's specific to the cause. And we don't just do generalized treatments like fusion anymore. It's unnecessary. It doesn't work well, and it's full of risk for the patient, complications. Go ahead, Henry. Show the audience Duke plasma rhizotomy for facetogenic pain.
Of course.
Facet joint injury is a common cause of chronic back pain. The inflamed facet tear generates pain signals. The best treatment for facet joint pain is the Duke plasma rhizotomy. Inflamed facet joint pain nerves are destroyed. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
Welcome back. Our video has shown you how an injured facet joint in your spine can be a cause of chronic back pain. Let's talk for just a moment about acute versus chronic back pain. What's the difference? The word acute means short-term or new. The word chronic means it's been around for a while. And we do have a medical definition, but it varies. Acute usually refers to a process happening that's 2 to 3 days old. It lasts 2 to 3 days, or it's been around for 2 to 3 days. We call that acute. Definitely less than a week or less. I feel the other needle from the patient's right side. It's in here. I can feel it with the grabber. I'm grabbing it and accidentally, and not on purpose, but not even accidentally, but it's down here underneath the herniations. I'm trying to remove the herniations too, but I keep grabbing the needle, which keeps me from pulling them out. All right, here is the tear, the back of the tear, and the tear is in the back of the disc. It's called a posterior annular tear, and we're in the back of the tear. So we're right at the end of the tear, right where it opens up into the foramen, right where the nerve root is. And you can see the laser is about 1 millimeter wide, and we're basically zapping away the herniation that's stuck inside the tear where it should not be. Now the nucleus is what makes up the herniation. The nucleus pulposus is a jelly-like tissue normally located in the middle of your disc, and when you get a traumatic injury to your disc, such as a fall, car accident, sports injury where you overstress your spine in your lower back, it causes the bones to move quickly and forcefully, and it doesn't fracture the bones, but it actually fractures the ligaments holding the bone together. Now those ligaments is called the posterior annulus, or annular tear is what rises. It's called the annulus fibrosus, and a posterior annular tear is a tear in that ligament around the nucleus pulposus, which makes up the center of the disc. So there's a jelly center and there's a firm ligament that goes around the jelly center. And when you get a tear in that firm ligament, called an annular tear, it allows the jelly to squeeze out under pressure. Like if you just do normal activities like sit down on the toilet or a chair or bend over to pick up a golf ball, you're putting pressure on the disc and you're putting pressure on the nucleus. And the nucleus pieces then are going to push against the bone, they're going to push against the walls, and they're going to find that tear. And the ones that are closest to the tear, they happen to be the ones that were damaged during the trauma. They fragment into little pieces, and they're going to push themselves right on out of the tear, right through the path of least resistance. So the tear is actually an opening. What is that, Luis?
What is that?
Got a little, like a haze or a halo. You see it, the blue? You think that's lens, or you think that's fluid?
Maybe water.
All right. So what happens is your traumatic injury causes a tear in this ligament that runs around the disc, holding the jelly in place. We call that an annular tear.
They're gonna repair this one for free anyways.
And
This is the one with the bubbles.
but I don't see a bubble.
Yeah, this one is the top one.
And the nuclear material starts coming out through the tear, and it gets stuck in the tear, pieces. So some of it leaves the tear and comes outside, some of it stays inside the tear, and some of it stays embedded in the tear. And the pieces that are embedded in the tear, because the tear is long, Those pieces cause inflammation within the tear, and that's what causes the back pain. Okay? So the source of back pain happens to be inflammation happening in the posterior annular tear, in the back of the disc. Now, if you have a tear in the front of the disc or side, those tears don't cause back pain because your body is wired differently so that those tears don't have sensation the same way you have sensation to the back of your disc. Any questions?
No current questions, but we do have a comment coming from Scott on LinkedIn
Sure.
saying, per AI, most back surgeries fail or don't deliver the expected long-term relief due to a combination of misdiagnosis, poor patient selection, unresolved root causes, and surgical limitations. This is often referred to as failed back surgery syndrome.
Yep. Scott, you're right. And I've been saying the same thing for years. The biggest reason spine surgery does not work for back pain is, number one, misdiagnosis, meaning the surgeon is doing an operation that is for the wrong diagnosis. Number two, multiple sources of back pain rather than one. That's a big one, which is not mentioned there by AI. AI unfortunately is limited that it just scours whatever the source of information it's using is. So if it's using, publications that are out there, then it's going to scour all the publications on the internet, right? But those publications could be wrong. There's an old saying, when you're doing data analysis, garbage in equals garbage out. So if you don't have good data going in, you're not going to have good data coming out. The reality is that the most common reason back surgeries fail is that the surgeon is making the wrong diagnosis. Number one. So I agree with that. Number two, the treatments that they use to treat diagnoses, such as fusion, laminectomy, they don't fix back pain. They create back pain. So the treatments are not designed to cure back pain, but the Duke laser disc repair surgery you're watching right now is designed to cure back pain. It's the only surgery designed to cure back pain besides the Duke plasma rhizotomy. All right, we're pretty much done with this disc on this side, the left. Next, I'm going to switch over to the right side because we're going to be doing the right side next at L45. It's a little piece of cartilage right there. You can see how there's bone. That's the surface of the vertebral body. Oh, we got a problem, Luis. And then you got some cartilage right there.
You're done with this?
Yeah. I'm going to switch to the other side. You can see the nerve root probably right up there. You see how red the nerve root is?
Yes, we can.
That's from inflammation. Got a little bit of fat there underneath it. That yellow stuff is fat, but that's the nerve root, and we just got the pressure off the nerve root by removing the herniation there. All right. So I'm going to finish up here by putting some antibiotics, and then I'm going to take this tube out on this side, and I'm going to go to the other side, which is her right. I'm going to fix the L34 disc on the right, because she has an annular tear on both sides at L34, in the left and right. We've just started with the left. We're going to go to the right next. You can see the incision is just 7 millimeters. We've lost maybe literally 1/1000th of the amount of bleeding you lose from a fusion. So she had fusion done already. We lost one. If you take her bleeding and divide it into 1,000 pieces from the fusion, we lost one so far of that 1,000 that she lost with the fusion. She may have lost 1,000 cc's. We've lost, well, actually we lost less than 1 cc. We've lost half a cc. So by the time we're done, we'll lose probably 1 cc of blood, which is 1 milliliter. It's a very small amount. Typical nosebleed has around 20 milliliters. So this is 1/20th of a milliliter, 1/20th of a nosebleed. Any questions?
Yes, we have a question coming from Cosmic Knight on YouTube,
Welcome back, Cosmic Knight. Nice to have you back.
asking Dr. Duke, could my base of skull tumor still be in an schwannoma and be touching the 12th cranial nerve, causing me to bite my tongue repeatedly in the same place? And a doctor said it was too low to be a AN.
Yeah, so very complicated question, related more to neurosurgery of the brain rather than the spine, but I'm happy to do my best to answer. So our viewer is saying there's two types of common tumors in the lower part of the skull and brain. One is called a schwannoma, the other is called a acoustic neuroma. And what they're saying is the doctor thinks his tumor is not an acoustic neuroma. It's actually a schwannoma. And I guess the question is, could that schwannoma be doing something with cranial nerve 12 that causes them to bite their tongue? The answer is absolutely. Cranial nerve 12 is the nerve that's responsible for moving your tongue, right? So if your nerve is being affected by the tumor, then you go to move your tongue, it's going to move on one side like you expect it to, but the other side, the side of the tumor, where the tumor is affecting the nerve, is not going to move properly. And it's not going to get out of the way of your teeth like you're expected to. Num num. So your tongue will move on one side but not the other. The side with the tumor is compressing the 12th nerve, affecting the 12th nerve. You can actually do an EMG of your tongue and see if you've got fasciculations of the tongue, which could be an indication that the nerve is being compromised. Is there a treatment for it? I don't know, to be honest. I don't know where you live. I don't know where you had your surgery, who your surgeon is. But I can tell you one thing for sure. I am definitely not the best neurosurgeon for managing brain tumors. I'm very good. If I had to do a brain tumor surgery, I could. I would do a very good job. But there are surgeons that do it every single day, brain surgery every day, take brain tumors out. And I would recommend you see one of them. How are we doing, Dr. B? Should I wait or proceed? All right, any other questions?
Yes, we have a question coming from Scott once more in LinkedIn,
Yes, Scott?
asking, do patients need to return to remove those staples?
Yes. Yes, they do, Scott. We take the staples out the next day. So we don't keep staples in for a week or two like other doctors. Because the incision is so small, we just put them in overnight. So our patients come back the next morning, and they actually have their staples removed the next morning. We substitute the staple for something called a steri-strip. So a steri-strip will be put on the next day. Why don't we just start with a steri-strip? Because what happens is these patients go back to the recovery room, their blood pressure spikes a little bit, they start squeezing out some blood, and the blood will then push the steri-strip off the skin, and that will then cause great consternation on the part of the patient. Why am I bleeding? And then we get a phone call at midnight, I have some bleeding. And then I'm obligated to bring them in and evaluate them when in reality there's absolutely nothing wrong. So by putting a staple, we avoid that scenario, and it's just better patient care. By the next day, the staple comes out, there's no bleeding at all, put a steri-strip on, send the patient back home. Great question, great observation.
And at this moment, no current questions.
I saw you move your fingers. What, you think I'm going to get you? Huh? Huh? Luis is a little gun shy? Yeah? Luis? I smacked his fingers one too many times over the years. Right. All right, we're working on the second side of L3-4 disc herniation, which is the right side. Why do we do both sides? Because this patient had pinched nerves on both sides. So we're going in to remove as much herniation on each side as we can to get the pressure off those nerves. And then we're going to move on to her sacroiliac joint, which was already fused, by the way, and still in pain. And we're going to move on to her piriformis, which is also in pain. Once again, misdiagnosed by other doctors and mistreated. All right, what do you think, Luis? You think water? All right, here's the herniation or part of it. Any other questions?
Yes, we have another question coming from Scott once more on LinkedIn asking, what are those 3 black dots? There are 2 sets of them.
You're talking about on the x-ray?
Yes, correct.
Yeah, I talked about that earlier. Those are the cages inside her discs. So those are the cages that the other spine surgeon put inside her, right? Remember, she saw some other spine surgeon first, and they convinced her to do a fusion, and now here she is back with more problems from the fusion. That's why I tell people don't do a fusion. And if you don't want to do a fusion, also you need to avoid laminectomy. Avoid laminectomy. Don't do laminectomy. Don't do discectomy. Don't do stimulator. Don't do fusion. Don't do ultrasonic nonsense surgery. Avoid all those bad surgeries, because those surgeries have one purpose, and that is to enrich the surgeon so that they can keep making money off of you, because those surgeries will never fix your back pain. As a matter of fact, anybody who doesn't believe me, go and ask your spine surgeon. If you're considering spine surgery wherever you live, go to your spine surgeon and ask them one simple question. Will your surgery cure my back pain? And they will not tell you yes, because I can't imagine they'll bold-faced lie to you. They're all going to tell you the same thing. No, our surgery is not going to cure your back pain. Our surgery may help your back pain. 50-50 chance of helping. 50-50 chance of getting 50% better. That's a standard line. And the reality is their surgeries will not help your back pain. They know that. That's why they're not going to promise you your back pain will go away, because they can't. We are all taught as spine surgeons there is no cure to back pain. And that's what I was taught. There's no cure to back pain. But the problem is I started curing back pain, and I started to ask, why am I able to cure back pain and other surgeons are not? And then I realized because I was doing things differently than them, much differently. And then I started to really focus on what was I doing different that was allowing us at Duke Spine to cure people's back pain. And that's when I came up with a long list of things that we were doing differently. And, oh, look at that inflammation right there. Those differences are important. As they say, the devil's in the details, right, Luis? Oh, yeah. So we started to focus over the years on what we were doing better than other doctors, other surgeons, how we were getting better results with curing back pain, until we perfected the technique. And it didn't happen overnight, folks. It took 20 years, actually longer than 20 years. It took about 27 years to perfect the treatment and curing of back and neck pain. And now we're able to cure virtually everyone's back and neck pain. Of course, we can't do it for tumors or infections. We do treat some infections of the disc. But if you're talking about tuberculosis of the spine with deformity, we don't treat that. All right, any other questions?
Yes, we have a long question coming from Pure Honest, Very Caring on Facebook.
Sure.
Asking, hi, I don't seem to understand why for 20 years on my MRI they say my discs are flattened, and when I asked about when I asked the surgeon doctors what is the solution, they start to stutter and they ask me, have you tried a new pain management, chiropractor, physical therapy, and all of them don't have access to unflatten. I obviously remember the chiropractor several times forcefully cracked and crushed my spine and back very deep, and when I was told when I told that to the surgeon, I feel it's fractured. They just keep saying you're not making any sense. When I get the S1 filled in and the C5, C6 filled in, will that give it access to unflatten, or can we try or request balloon kyphoplasty, minimally invasive solution to vertebral compression fractures?
Yeah, so to answer your question, as I've been saying literally every time I operate over and over again, and I guess some people don't hear it, the other doctors do not know what's causing your back pain. I do. I make this statement, you sit there and go, who the fuck are you, Dr. Duke Machen, to think you're the only one that can diagnose back pain? But I say it for a reason, because I am. Duke Spine has a special technique that allows us to realize what's causing your back pain, whereas every other doctor does not know. That's why other doctors will not do surgery to cure your back pain, because they have no clue where it's coming from. I say this every single time I operate, and people just don't get it. The reason you keep going back to your doctors, showing them your flattened discs, and they have no idea what to do, is because they have no idea what to do. We do. You need to come to Duke Spine. There's an old saying, the definition of insanity is when you keep doing the same thing over and over again and you expect a different answer. So you keep going back to your doctors for help and they're not helping you. And you think, I don't know what you're thinking, but what you should be thinking is, how do I get myself to Duke Spine Institute so that Dr. Duke Machen can fix my back and take away my pain? Okay, you don't have a fracture. I don't think you do. There is a test you can do if you're not sure, and that test is called a bone scan, a nuclear medicine bone scan, and that will show you if your bone is fractured, even if your MRI doesn't show it. Okay, a nuke med study. If I had a suspicion that you had fractures causing your symptoms, then I would order a nuke med study, but I do not. I think your pain is coming simply from your discs or your facet joints, is what it sounds like. The other doctors you're seeing do not know that. They will never know that. They're beyond help. So the question is, are you beyond help? Are you willing to change your way you think, what you do, and stop going and doing the same thing and expecting a different result? You understand? All I can do, folks, is empower you with knowledge, which I've been doing every single day I operate. What you do with your knowledge is really up to you, but I can't, you can lead a horse to water, but you can't make it drink. You guys have to listen carefully to what I'm saying. I'm trying to say it without being arrogant. I'm trying to say it without you guys judging me, saying, who the fuck is this neurosurgeon to say he's the only one that can do this? But I am. That's the fact. In the world, I am the one. And if you want to get cured, you have to come to me, period. Your other doctors will not help you. They don't know how to help you. That's the problem. They don't know how to help you. It's not that they don't want to help you, they don't know how to help you. But doctors don't like admitting that they don't know how to do something. So they tell you to take pills, or they tell you to go to therapy, or they tell you to, do a stimulator, or they tell you to do something, because they don't want to feel useless to you, the patient. That's one thing doctors don't want to do. They don't want to feel useless. Okay? So what they try to do is they try to give you the standard answer. Go to physical therapy, take a pain pill, take some Neurontin, take some gabapentin, take some Lyrica, take some narcotics, take some anti-inflammatory, take some muscle relaxer. The list goes on, but none of those treatments will ever fix your pain, ever. Right, Henry? How many times can I repackage the answer for these people?
It's too many to count, I'll tell you that. But
They love listening to me,
yeah.
but they think I'm just some little toy poodle that, he's cute, but, I've got a different dog. I'm just going to go to my cute little dog. No. There is no other cute dog in this case. There is nobody else that's going to help you with your pain. Period. I don't know how else to say it, but not come across, that way.
Apart from that, no current questions.
Well, good, because we're just about done with this disc. I got about 3 minutes left. You can see all the scar tissue here from chronic inflammation. This is the back of the tear, the painful part, the really painful part. Now, why do we not just focus on the back of the tear? Why do I clean the whole tear? Because if I don't clean the whole tear won't heal. If I just clean the back will heal. But that means the middle and the front of the tear won't heal. So do you want to still have a middle and front tear? No, of course you don't. Because that middle and front tear, if it never heals, it's just going to come back again, right? It's just going to rip the back again. So you gotta heal the entire tear. That's why I clean the entire tear. Even though the front and middle of the tear, they really don't do anything significant in terms of pain, but they need to heal. Otherwise, you're going to be back again with the same problem, another tear. So to get the whole tear to heal, right, you gotta clean the whole tear. This blue stuff is herniation. It's stuck inside the tear. This is the lateral part of the tear we're looking at now. I've turned the scope. I'm looking laterally towards the flank. All right. For those of you who don't know what lateral means, it means to the side of the body. Medial is to the midline. Lateral is the opposite direction. It's one of the things that doctors learn in med school your first week, medial and lateral. They're just reference directions, reference vectors. Very important, though, to understand them. All right, we're just about done with these L3-4 Duke laser disc repair. Our patient had stenosis that was pretty bad. Hold the tube. The stenosis was pinching the nerves, causing weakness in her legs, and pain in her back above her fusion. Now I'm going to go and basically address the other causes of her back pain that we know about, which is her SI joint, which was already fused. The fusion was supposed to take care of that pain, but it didn't. And I'm going to go address her piriformis muscle. Okay? Let's see the laser one more time. Any other questions? Last chance saloon.
Yes, we have a question coming from Cosmic Knight once more on YouTube, asking if they did a biopsy, would they likely remove it entirely when it's open? It does hurt at tumor site in my neck. Also, can these turn malignant?
So, yeah, so whether you have an acoustic neuroma or a schwannoma, pretty much the same thing, they do turn malignant. 10% of them will become malignant over time. It usually takes 10 years. 10% in 10 years. That's the old saying. Will they remove it? No. If they're biopsying it, then they're not removing it. They're just trying to get a diagnosis. That's all. So a lot of times surgeons will get a piece of tissue, scope off, rather than trying to take the whole tumor out. I don't know why your surgeons would not take the whole tumor out, but it could be they're not trained or competent to do that, which means they're not a very good neurosurgeon. B, the tumor is not completely resectable because it's wrapping around arteries or nerves that make it impossible to surgically dissect the tumor away from. Or C, your facility doesn't have the technology, the equipment, the staff, the resources, we call it, needed to do a resection. Or because a resection would put you in such a bad neurological condition, not able to swallow, not able to manage your secretions, that you would basically just aspirate and die. So there's a high risk of complications, and they don't have the resources to manage your complications. Okay, so there's skill of the surgeon, there's equipment of the facility, trained staff available to deal with all the stuff that comes along with that kind of a surgery. There's a lot of variables here. Maybe it's not resectable, okay? Maybe it's treatable with some other modality, we call it. All right, we are done. Let's go ahead and end the stream. We'll be back to do the sacroiliac joint.